Hello, my name is Melike Harfouche, and I'm an assistant professor at the University of Maryland School of Medicine and a trauma surgeon at the Scalea Shock Trauma Center. Our paper is titled A Cautionary Tale, the Use of Propensity Matching to Evaluate Hemorrhage-Related Trauma Mortality in the ACS TQIP database. Propensity match methods are increasingly being applied to ACS TQIP due to the abundance of data points. However, this may not be appropriate for evaluating hemorrhage control interventions. We use variation in systolic blood pressure to demonstrate flaws in this approach. ACS TQIP from 2017 to 2019 was used, and patients were divided into 3 groups based on their initial systolic blood pressure shown here. The immediate decompensation group was hypotensive on arrival and remains hypotensive to less than or equal to 60 millimeters mercury within 1 hour. The stable hypotension group was hypotensive on arrival, but remained above 60 millimeters mercury within 1 hour, and the delayed decompensation group arrived with a blood pressure greater than 90, but decreased to less than or equal to 60 within 1 hour. We excluded head or spine AIS greater than or equal to 3, and our main outcomes of interest were in-hospital mortality, ED mortality, and overall length of stay. Shown here is our final study population. We started with approximately 3 million observations in TQIP. However, several patients had to be excluded due to our exclusion criteria and missing variables. Ultimately, we had 26,000 patients in our final study population, with 4,640 in the delayed decompensation group, 7,680 in the immediate decompensation group, and 13,983 in the stable hypotensive group. We performed propensity matching in a one-to-one fashion, and propensity score was assigned using age, sex, GCS, mechanism of injury, pre-hospital cardiac arrest, ISS, and percentage AIS scores 3 or greater for chest, abdomen, pelvis, and lower extremity. Shown here are our results for our main outcomes after propensity matching. Analysis 1 is a comparison between the stable hypotension and delayed decompensation groups. Mortality is significantly higher for both ED deaths and in-hospital mortality for the delayed decompensation group at 10.6 versus 3.6% and 29.7 versus 15.4%. Similarly, immediate decompensation group fared much worse compared to the stable hypotension group, with ED deaths of 22.6% versus 4.3% and in-hospital mortality of 40.5% versus 17.6%. On univariate analysis, odds of in-hospital mortality were 2.3 times higher for the delayed decompensation group compared to the stable hypotension group, and 3.2 times higher for the immediate decompensation group compared to the stable hypotension group. There is a large variation in mortality rates amongst trauma patients with likely hemorrhage when stratified by changes in SBP using this database. This underscores the difficulty of comparing similar patients using ACS TQIP despite the benefits of propensity matching. The lack of base deficit, lactate, and pH in this database further bias the matching process. Therefore, our take-home message is as follows. Large databases such as ACS TQIP lack the detailed data needed to rigorously evaluate hemorrhage control interventions. Thank you very much.